Let's talk now about wound complications. Vignette number 37. On the 5th post-operative day after laparotomy, it is noted that large amounts of salmon-colored clear fluid are soaked in the dressings. Classical thing, something that we should recognize for what it is. This is the classical presentation of wound dehiscence. The skin's still together. We don't see an open wound. But underneath that skin that is still being held together by fibrin and not much more, all the other deeper layers have failed to heal. And that pink fluid, that clear salmon color fluid we're looking at, is actually peritoneal fluid. Peritoneal fluid that is seeping through and soaking the dressing. And it is pink because due to the recent operation there's a little blood in it. If we don't recognize what this is, and we allow that patient to cough or move or put increased intra-abdominal pressure, we could then go on from this relatively benign situation we have right now to the catastrophic situation of evisceration. And so if you're given this vignette, the diagnosis, of course, is wound dehiscence, which is not the same as evisceration, wound dehiscence. And the management would be very careful protection of that wound because there isn't much that's holding it together. This patient would need to be kept in bed, advised not to do a lot of movement and increasing intra-abdominal pressure, and we would help him as best we can by taping the wound together, by using perhaps abdominal binders, something that helps us keep together the abdominal wound. At a later date, whenever it becomes convenient to do so, the patient is going to need to be reoperated because if we leave him alone this way, he's going to have a huge ventral hernia. But this is not an emergency as presented. That repair could be at a convenient time in the future. This, however, could become an emergency if it is not recognized. Let's read the next vignette. Vignette number 38. The nurses report that a patient on his 5th post-operative day after a laparotomy has been draining clear pink fluid from his abdominal wound. A medical student removes the dressing and asks the patient to sit up so he can get out of bed and be helped out to the treatment room. When the patient complies, the wound opens widely and a handful of small bowel rushes out. Well, this is what we were trying to prevent on the previous vignette. Now the diagnosis here, if you're asked for it, this is evisceration. This is no longer wound dehiscence. This is now evisceration. The bowel is out. Not a laughing matter, by the way. This has a very high morbidity and mortality. And so if you're given this vignette and asked for management, what is done is the patient is put back in bed, and that bowel has to be covered with large, moist dressings soaked in warm saline while arrangements are being made to rush this patient to the operating room for reclosure. The two key things in this immediate management are warm and moist. You don't want that small bowel to dry out. That's bad for the bowel. And you don't want the patient to become hypothermic. So that's why the two key components of what you do as you cover that bowel is soaked in warm saline. All right, let's move to another one. We touched upon this a little earlier, but now we see it from a different perspective. Vignette number 39. On the 7th post-operative day, the inguinal incision of an open inguinal herniorrhaphy is found to be red, hot, tender, and boggy. The patient reports fever for the past 2 days. This is a wound infection. Remember, fever post-operatively, if it's due to a wound infection, is typically late, like 5, 6, 7 days out. And here the physical findings clearly indicate this is a wound infection. What do we have to do about a wound infection? Well, it depends. If all we have is redness without a fluid collection, and we're thinking this is just cellulitis, antibiotic treatment is what we need. An antibiotic treatment, incidentally, geared to normal skin flora. That's what this would be. This was a hernia repair. The bowel was not entered. So you would have no reason to think that this is colonic flora. This is probably skin flora. But on the other hand, if there is pus, that will not suffice. In the presence of an abscess, drainage is the only effective treatment. Now the fingers, the examining fingers may be able to tell. An experienced clinician can feel that wound and either detect the presence of the fluctuant mass of the fluid collection and therefore proceed to open the wound and drain the abscess, or the fact that there is no such thing. But as I pointed out earlier, if these were not clear, and the question on the exam asked you, how can you tell if there is an abscess or not? The answer would be a sonogram. The sonogram can clearly show the presence of pus there in the wound or the absence of the pus. Vignette number 40 reads, 9 days after a sigmoid resection for cancer, the wound drains a brown fluid that everybody recognizes as feces. The patient is afebrile and otherwise doing quite well. Now, by definition, if we have luminal content coming out through the belly wall, this is a fistula. We furthermore know that this fistula is not draining from a partially drained collection of intraluminal contents, because if that had been the case, the patient would have been febrile. So this is not a leak from the anastomosis leading to an abscess from which in turn there is a little content coming to the outside. In that setting, the patient would have fever and not really be doing well otherwise. This is not peritonitis either. This is not a disruption of a surgical anastomosis that has led to massive contamination of peritoneal cavity with intraluminal contents. If that had been the case, we would have been told that the patient looked very sick and had tender abdomen and rebound and so on. So these two things here. We have a patient who's afebrile, seems to be doing fine, except here's this little fluid coming out. This defines the situation as a fistula. Now what do we need to do for it? Well, in this particular example, not very much. Let me review with you what's wrong with having a fistula of the GI tract. If the fistula were to be high volume and coming from high up, a lot of things would be wrong. Let's say that you had a patient putting out 2 or 3 liters a day coming out of a duodenum. That patient would have a severe fluid and electrolyte problem, because any fluid that patient drinks would go out the fistula, plus the gastric juice and the saliva and the duodenal contents. So this patient would have a problem with fluid and electrolyte replacement. That patient with a high output, high fistula in the GI tract would also have a problem with nutrition. Meat and potatoes that patient might eat would go out through the fistula, not give him the necessary nourishment. That patient would also need nutritional support. And furthermore, a fistula from high up in the GI tract, the fluid coming out is loaded up with enzymes. Enzymes that were designed to eat meat and potatoes, to digest the food, and now they are digesting the abdominal wall as they come out. But in the case that we have just read, if this is coming out of a sigmoid, there isn't much fluid absorption that takes place from sigmoid contents. Neither is there any nutritional value left in the contents, nor are there enzymes. So now we're talking about a situation that is inconvenient for the patient. It is a nuisance to have feces come out of the belly wall rather than through the rectum, but it's not life-threatening. Now, most fistulas of the GI tract, particularly the ones we're dealing with in this example, subsequent to an anastomosis, Most of those fistulas eventually heal unless there is something to prevent them from doing so. And in this particular case, you essentially would not be justified in having any drastic intervention. Don't pick the answer for this vignette where you do a colostomy, where you go in and repair the fistula, where you put the patient on parenteral nutrition. You don't need any of that. This is not a life-threatening situation. Leave it as is. It will probably get better as you go along. Let me emphasize that it would have been different. You've been told the patient has fever and leukocytosis. And you would have had to go in and drain this collection of intraluminal contents. Or if you've been told the patient has an acute abdomen, yes, you would have had to intervene immediately. And probably in those two situations, you would have ended up with a colostomy, because it would have been impossible to put together things again in the middle of a very inflamed, highly contaminated environment. But now when we get to the next vignette, we're going to see the example of a GI tract fistula that needs very intensive care. Vignette number 41. 8 days after a difficult hemigastrectomy and gastroduodenostomy for gastric ulcer, the patient begins to leak 2 to 3 liters of green fluid per day through the right corner of his bilateral subcostal abdominal wall. Now we have a fistula that is high in the GI tract and it is high volume. If the vignette doesn't say that the patient has signs of peritonitis, and we know he didn't leak into the peritoneal cavity, he doesn't have the need for immediate intervention. And if we're not told that he's spiking fever, leukocytosis, we again are reassured that this fluid comes straight out from the duodenal anastomosis to the outside without pooling on the inside in a way that would have required drainage. But now we have a big problem. Well, your intuitive answer might be, this is a mechanical problem. This is an anastomosis that fell apart. Let's put it back together again. So you might want to pick the answer on the exam that says immediate reoperation for reanastomosis. But that's easier said than done. To reoperate in the presence of a fresh fistula that just developed, that operative field is a nightmare. Things are going to be inflamed, anatomical structures are going to be difficult to recognize, sutures are not going to hold. We prefer not to operate the GI tract fistula if we can avoid it. And in most instances, we can avoid it. And here's what you would do for this patient. First of all, fluid and electrolyte replacement. If the patient is putting out 2 to 3 liters a day from that fistula, he needs that in addition to his maintenance fluids. So if that patient already was requiring, let's say, 3 liters a day maintenance IV fluids because he's not eating, he would now need 5 or 6 liters a day. The 3 that he needs for himself anyway, plus the 2 or 3 that are coming out. The 2 or 3 that are coming out should match the electrolyte content, in the fluid that we use for replacement. Match electrolyte content of fluid that's coming out. And duodenal fluid. This is green fluid, duodenal fluid. A great portion of that is going to be bile and pancreatic juice, highly alkaline fluids that have a sodium content very similar to that of plasma, but a little less chloride or more bicarbonate. And probably a good replacement fluid here for the fistula content would be something like Ringer's lactate. So we need the fluid and electrolyte replacement. We also need nutritional replacement. There is now no way to feed this patient by mouth. And so the patient will need either, and this would be the preferable route, delivery of an elemental nutrient solution to the GI tract distal to where the fistula is, or if that is not possible, then parenteral nutrition. Anytime there is a choice between enteral and parenteral nutrition, enteral is a better idea. Obviously, we couldn't drip it into the stomach because it'll go out the fistula. But if we can place a catheter distal to the fistula, we can put a catheter to go in and advance beyond and end up in the first portion of the jejunum, beginning of the jejunum, beyond the ligament detritus. Or if the patient had maybe a feeding catheter jejunostomy placed at the time of surgery, this would be a good route by which to deliver elemental nutrients. Not meat and potatoes that have been put through a blender, because that would increase enzymatic activity, but an elemental nutrient, something like Vivonex, that doesn't stir up enzymatic activity. So we've taken care of fluids, electrolytes, nutritional support. The other thing we need to take care of and be very compulsive about is protection of the abdominal wall. Remember, the fluid coming out was designed to digest meat and potatoes. Left there soaking a dressing in contact with the skin is going to digest away the skin and the abdominal wall. So very compulsive protection of the abdominal wall is needed. This can be done by rigging very imaginative suction devices, using something like an ileostomy bag. So the fluid drains into a contained place, not soaking dressings all over the abdominal wall. And then protecting what little skin is inside this device with something like zinc oxide or caraya powder or one of those things that can be glued to the skin. And then perhaps a suction device that keeps sucking away all the fluid that comes. In other words, we have to keep that evil fluid away from the skin. If we do that, then those would be answers that probably would be offered to you on the exam question. We have reason to hope that the fistula may close, because GI tract fistulas, if they are not a gigantic disruption, complete disruption of an anastomotic line, if they are a little small area, have a tendency to heal if a patient is properly supported. And that way we avoid that operation that we don't want to do in the first place. Now let me review, though, what are the circumstances that prevent the fistula from healing? Because any one of those, if given to you in the vignette, would indicate, unfortunately, the need for surgical intervention. There is a mnemonic that we give to medical students to remember this. The things that prevent the fistula from healing, the word is fetid. F-E-T-I-D. The F stands for foreign body. If there is a foreign body in this fistulous tract, the body cannot heal right through it. If a catheter was left there, perhaps if there is a sponge, if there is a foreign body, this will prevent the fistula from healing. Such foreign body would have to be removed. The E in the mnemonic fetid stands for epithelialization. Let me explain that. In the process of healing a fistula, two things happen at the same time. Granulation tissue grows from the walls of this conduit that the fistula is to plug the lumen. And at the same time, epithelium is migrating from inside the lumen in the direction of the hole, from the skin in the direction of the hole. If we have a fistulous tract that is long and narrow, the granulation tissue is probably going to win the race, so to speak, and fill the lumen before the epithelium that grows from the bowel and the one that grows from the skin could meet in the middle. That fistula, therefore, will close. But if we have a short and wide fistula, too wide for the granulation tissue to quickly fill in, and close enough between the skin and the mucosa of the bowel, then the epithelium that migrates in from the skin, the epithelium that migrates out from the bowel are going to meet in the middle. The fistula then becomes epithelialized, and now this is a permanent thing. And that fistula will not close. That fistula will need to be operated on, will need to intervene to get rid of that epithelium to allow it to heal. I might add, incidentally, as we go through this, because it might have application in other exam questions, that these two things that I've talked about, the foreign body preventing the healing of a fistula, the epithelialization preventing the healing of a fistula, are two features that we use ourselves therapeutically when they are convenient for us to use. If we, for instance, want a temporary connection between a hollow inside viscera in the body and the outside, we establish that connection with a tube. When we do a tracheostomy, we put a cannula there. When we do a gastrostomy, we put a tube. That tube keeps that connection open because that's the foreign body that prevents closure. When we no longer need that connection, when the tracheostomy is no longer needed, when the gastrostomy has outlived usefulness, we don't need to go back to the operating room to sew up the hole. We simply remove the foreign tube. When we take this cannula, that foreign body that was in the trachea, the tracheostomy heals in. When we remove the tube in the gastrostomy, it heals in. On the other hand, when we wish to make a permanent connection between a viscera and the outside, we sew up epithelium to epithelium. When we do an ileostomy, when we do a colostomy, if they are meant to be permanent, we actually sew up epithelium to epithelium. We epithelialize it right in the operating room, and it doesn't then need a tube to keep it open. It'll be open forever. Now, in the context of a fistula, then, these two are indications for surgery. So if you had a question on the exam that says the patient has a fistula, as described, and X-rays reveal that there is a sponge in the fistula's tract, well, then no amount of nutritional support and fluid and electrolyte replacement and care of the abdominal wall is going to lead to healing. We will have to remove that foreign body. Or should the vignette say, a short and wide fistula's opening has epithelialized, well, again, now we need intervention. Let me continue with this mnemonic of the things that keep a fistula from healing. We'll talk about the foreign body and the epithelialization. The T of the fetid stands for tumor. A fistula that occurs not through normal healthy tissue, but occurs through a tumor, doesn't heal just because we provide general support. So if a vignette on the exam had been, the lady has cervical cancer, it has eaten right through the walls of the vagina and the rectum, and she now has a rectovaginal fistula, well, then the healing of that isn't going to happen with any kind of just conservative support, because we don't heal fistulas that occur through tumor tissue. The I in the mnemonic stands actually for three things: infection, irradiated tissue, or inflammatory bowel disease. All three of these are examples of situations where there is no spontaneous healing to be expected. So again, if we were to be told in the vignette that there is a fistula, but there is an abscess between the lumen of the viscera and the outside, unless we drain that abscess, get rid of that infection, that fistula isn't going to heal. And by the same token, the fistula that is secondary to radiation, it's irradiated tissue, it will not heal, neither will the fistula that is due to inflammatory bowel disease like regional enteritis. Again, surgery is needed in those. And finally, the D stands for distal obstruction. If, let's say, in this same vignette we read, the patient that had the gastroduodenostomy that subsequently leaked, we were told in that vignette, X-ray studies have been done. We have injected dye through the fistula, a fistulogram. And this dye goes into the lumen of the bowel, and it shows that just beyond this place, there's an adhesive band that is occluding the lumen of the bowel. Well, if there is that distal obstruction, the fistula will not heal. Again, surgical intervention will be needed to get rid of the obstruction. Well, we're done with the fistulas. I know that took a long review and a long explanation, but we covered many different facets that might be parts of the question. And now let's move to fluids and electrolytes. Now, some of the scenarios that are going to be reviewed now, we have just reviewed in the context of a patient that became disoriented and went into coma. But now we're going to look in a little more detail at the actual fluid and electrolyte problem and what is it and what do we do about it. So we're going to read something that will sound familiar. 8 hours after completion of a transsphenoidal hypophysectomy for a prolactinoma, a young woman becomes lethargic, confused, eventually comatose. Review of the record shows that her urinary output since surgery has averaged 600 cc's an hour, while her IV fluids are going in at 100 cc's an hour. The serum sodium determination shows a concentration of 152 milliequivalents per liter. Remember, this was a test we would have wanted to do had we been given only the clinical description. And this concentration of 152 indicates that the patient has lost water, which she did by virtue of a diabetes insipida and the very diluted urine that she's been putting out in large amounts. But now we're looking at this from the perspective of fluids and electrolytes. Let me review this in a way that could be applicable to other exam questions. Anytime you see an exam question that gives you a higher than normal value for serum sodium concentration, in the vast majority of cases, that will mean the patient lost water rather than meaning the patient gained sodium. When you gain sodium, you typically gain fluid right along. You end up with edema or with ascites, but typically not with hypernatremia. So hypernatremia means you have lost water. Well, in this case, we know this happened acutely. It happened in a matter of a few hours as the patient developed his diabetes insipida, secondary to the surgery in the vicinity the pituitary gland. So this patient then can be safely treated with a diluted fluid that replenishes the water that she lost, because what she has is not chronic hypernatremia, but hypernatremia of acute development. So this lady could be given several liters of D5W, could be given perhaps 1/3 or 1/4 normal saline to be rehydrated. There is a little guideline that you could apply to a case like this. When you realize from this vignette that this is strictly loss of water, and this is what's happening. Every 3 milliequivalents that the serum sodium concentration is above the normal of 140 represents roughly 1 liter of water was lost. And although this is only an approximation, it would give you an idea that if this individual went to surgery with a serum sodium of 140 and now has 152, she's lost about 4 liters of water. And that's what she needs, about 4 liters of water. She also needs antidiuretic hormones so this doesn't continue to happen. But now the next vignette gives you a very similar situation as far as fluids and electrolytes are concerned, but in a very different setting with very different implications for treatment. And in fact, the vignette is based on situations that we unfortunately see quite commonly in the city of San Antonio, Texas, where I've done all of my surgical practice. Let's read the vignette. Vignette number 43. A group of Mexican nationals are smuggled into the U.S. in a closed metal truck. When the Border Patrol chases them, the smugglers abandon their charges in the middle of the desert in the locked truck with no water to drink. The victims are found and rescued 5 days later. One of them is brought to your hospital, awake and alert, with obvious clinical signs of dehydration and the serum sodium concentration of 155 milliequivalents per liter. Well, let me go back to the basic diagnostic thought that I already outlined. A higher than normal serum sodium concentration doesn't mean the patient has gained sodium. It means the patient has lost water in most cases. Well, here again we know how it happened. For 5 days the patient has had no water to drink, but he still is breathing and evaporating water via the lungs. He still evaporates water through the skin. And even if he has reduced his urinary output to a very minimum amount, he still is losing water every day that he's not replacing. And not surprisingly, the serum sodium concentration when he's finally rescued is considerably higher than normal, 155. He has selectively lost water rather than water with sodium at a similar concentration of that of a plasma, because he's being evaporating pure water through the lungs, evaporating almost pure water through the skin, not water and sodium in an isotonic concentration. Well, you might say, we can see what the problem is. The patient has both hypernatremia, that is to say he's got hypertonicity of his body fluids, and he's also badly dehydrated, and he's lost approximately 5 liters of fluid. If we use our little calculation, every 3 milliequivalents per liter above normal represents 1 liter roughly. And so you might say, let me look for the answer where we give this man 5 liters of D5W over the next few hours. But if you pick that answer, you pick an answer that kills the patient. And therefore you won't get that point right on the USMLE. When we have hypernatremia developing over several days, like this one did, not a few hours like the previous one, but several days, the brain has time to adapt to what's happening. And so this is why the patient, when rescued, even though it's clearly dehydrated, still has a functioning mind. We're not told that this patient was in coma or even confused, lethargic, and having convulsions. He is in fact mentally pretty clear, because he's being able to adapt over 5 days to the change in tonicity. If we now were to very quickly revert that tonicity, the brain wouldn't have time to disadapt to the adaptation that already took place, and we would in fact kill the patient. Well, you might say, all right, that gives me a hint of what's the correct answer. Let's give him 5 liters of D5W over the next 5 days. So we take our time to very gradually, very slowly correct the problem, but that's not a good answer either. Because there is no advantage to a dehydrated, volume-depleted patient. There's no advantage to that individual to remain volume-depleted for 5 days. When we have the combination of volume loss and tonicity change, which happened over several days, we want to reverse the volume loss pretty quickly. We want within a few hours to put volume back into that patient so hemodynamic situation is better, so the kidney works better. We want the dehydration corrected in a few hours, but we don't want the tonicity corrected in a few hours. We want several days to do that. We achieve this split rate of correction by the choice of the fluid we use. If we were to give him 5 liters of D5W in a few hours, the tonicity would be corrected too quickly. If we gave him 5 liters of normal saline over the next few hours, we would barely make a dent into his tonicity. We're giving him something that is very similar to the tonicity of his existing fluid. So we pick something in between. And in fact, a good answer for this vignette would be 5 liters of D5, 1/2 normal saline over the next several hours. And by picking that fluid that is neither as diluted as D5W nor as concentrated as normal saline, we can achieve a rapid correction of the volume while at the same time having a relatively more modest impact on the tonicity. Let's move on. We're now going to read again something that we already read before, but now looking at it from a different perspective. Vignette number 44. 12 hours after completion of an abdominal hysterectomy, a 42-year-old woman becomes confused, lethargic, complains of severe headache, has a grand mal seizure, and finally goes into coma. Review of the chart reveals that an order for 5% dextrose in water, D5W, to running at 125 cc's an hour was mistakenly implemented as 525 cc's an hour. Her serum sodium concentration is 122 milliequivalents per liter. We have to assume that at the time of surgery, if it was normal, it was 140. It has gone from 140 to 122 in a few hours. This is acute water intoxication. Let me again make the general statement that could find use in other clinical vignettes. As a rule, when we're told on an exam question, the patient has a serum sodium concentration lower than normal, it doesn't mean the patient lost sodium, it means the patient has retained water. Even if the latter happened in a runabout way that began with the loss of sodium-containing solutions. We'll get to that in a minute. In this particular case, in fact, there is nothing in the events that have happened here whereby sodium could have been lost. The patient simply had a very rapid drip of a sodium-free solution, D5W, going in very quickly at a time when inappropriate ADH, as part of the response to trauma, has retained it. This lady has very quickly diluted her body fluids. She now has every cell in the body swelling, including the cells in her brain, and this is why she's comatose, and it happens so quickly she has had no opportunity to adapt to the change. Her brain has not been able to keep up with events. We can treat this lady with hypertonic saline, perhaps with mannitol, and as I pointed out before, this is a high morbidity, high mortality type of situation, best to be avoided by not infusing a large amount of sodium-free fluid to someone in the post-operative period. But that would be the correct management in this case. Very judicious, careful use of either 3% saline or 5% saline, which are the two hypertonic concentrations at which it is available. A very small aliquot at a time. If we're using 3%, no more than 500 cc's before we reassess the situation. Some people might say even less, 200-300 cc's and reassess. If we're using 5% saline, certainly very small aliquots, 100 cc's, maybe 150, and re-evaluate the situation. But the next vignette gives us a situation that is more important from the viewpoint of avoiding inappropriate treatment. Let's read vignette number 45. A 62-year-old woman comes in for her scheduled chemotherapy administration for her metastatic cancer of the breast. Although she is quite asymptomatic, the lab reports that her serum sodium concentration is 122 milliequivalents per liter. Same value as we saw in the previous one. But this is a very chronic situation. We can also easily explain it. As you know, one of the things that metastatic cancers are famous for is their ability to make hormones. I'm sure you remember the paraneoplastic syndrome. And in this case, the hormone being made is antidiuretic hormone. And so the patient, by virtue of a little trickle of antidiuretic hormone that is made by her tumor, from her normal fluid intake, she retains more water than you and I would retain. And given that she has gradually, slowly developed this hyponatremia. How do I know this happens slowly? Because I'm told that the lady is mentally clear. She's asymptomatic. And I know, therefore, that her brain has had a chance to adapt to what has occurred. If we now were to correct this tonicity in a few hours, we would kill the lady. Or at the very least, give her a bad case of central pontine lysis of her myelin and cripple her, potentially in an irreversible fashion. And so, if we feel compelled for some reason to correct the serum sodium, it has to be done very slowly, very carefully, and the safest way to do it would be simply water restriction. We know that the normal water intake that she has leads to retention. We unfortunately cannot take away the ADH she's making, the tumor is making, and the tumor is already extensive, we cannot remove it. Well, if we instruct her to drink less water, there will be less water to be retained. She will slowly, gradually go back to a more normal value for her serum sodium. We could also, by the way, use medications that counteract the effects of ADH. This is another option in this lady. Now, I mentioned a little while ago that when we see a lower than normal serum sodium concentration, we should think water retention has occurred. And this is true even in the cases where the problem began with the loss of sodium-containing fluids. You see, a low serum sodium concentration could never be simply, quote, loss of sodium. Let me push this a little further, because I think it's worth reviewing, and it will give you a framework useful in other questions. If we see a patient with a lower than normal serum sodium concentration, and we ask, well, what happened to this individual? And the answer were to be given on rounds, well, she must have lost sodium. The sardonic, the nasty follow-up question that comes is, oh yes, did you see the patient vomiting bicarbonate powder? Has the patient been urinating tablets of salt? Because you see, there is no way to lose from the body sodium as a solid. The sodium we can lose from the body has to be dissolved in body fluids. And given that challenge, the person who suggested the patient has been losing sodium might regroup and say, well, I didn't mean solid sodium, I meant the patient has been losing hypertonic fluids, and therefore the fluids left behind are now concentrated. But you know, that's not the situation either, because there are no hypertonic fluids that you can lose from the body, with the only exception of urine, but in that case it's because the kidney makes it hypertonic. Yeah, we can put out hypertonic urine, but in that case the kidney is in fact doing the right thing, if it's appropriate, to put out hypertonic urine. But the fluids we lose from the GI tract are isotonic fluids. The fluids we might lose by evaporation from the skin are almost pure water. Evaporation from the lungs is pure water. There is no mechanism to, quote, lose sodium or, quote, lose hypertonic fluids. That would end up then with a hyponatremic patient. But there is a sequential condition where it can happen. Let me read this vignette. A 68-year-old woman comes in with an obvious incarcerated umbilical hernia. She has gross abdominal distension, is clinically dehydrated, and reports persistent fecaloid vomiting for the past 5 days. She is awake and alert, and her serum sodium concentration is 118 milliequivalents per liter. But this is what has happened in this lady. She began by losing isotonic fluids from the GI tract. The fluid that is pooling in the lumen of her obstructed bowel, the fluid that she is vomiting, is isotonic fluid, sodium containing, but at the same concentration of the plasma. The initial abnormality that developed in this lady was pure volume contraction, pure dehydration with no tonicity change to begin with. But if she has been severely volume depleted for several days, and given the fact that she's vomiting and has an incarcerated hernia, she's being unable to eat and drink in the normal way, she has not been able to replace the fluid that's missing. Now she is thirsty and her body is eager to retain fluid. If she had been given isotonic fluids to replace the isotonic fluids she lost, she would never have developed this hyponatremia. But when patients are vomiting or have diarrhea or have abdominal problems and they are losing GI tract fluid and they get thirsty, typically what they drink is not a bicarbonate solution or a salt and bicarbonate solution. They drink water or Coke or tea, things that have no sodium. Even if they drink nothing, the catabolic state in which they are, since they are not eating either, leads to production of free water. Every time we break down cells to get energy out of them, every time we burn fat to get energy out of them, we make water in the process, water that has no sodium. Either the water that was endogenously produced or the water the patient drank has now been retained, because given the desperate state of volume depletion the patient is suffering, the body is willing to sacrifice tonicity in an attempt to replenish volume. And so the water drank, the water generated is retained. It doesn't do an awful lot to correct the volume depletion, because as soon as you create the tonicity gradient, that water ends up in every cell in the body. But you end up with the electrolyte pattern described here. The patient has now a low concentration of serum sodium due to the fact that she has retained water, which in turn was due to the fact that she had lost isotonic fluids. I suppose if you stretch a bit the definition, you could say this is a patient who was hyponatremic because she was losing sodium. I want to emphasize it's a sequential pattern. She lost isotonic fluid, she eventually retained water, and that's how she became hyponatremic. What are we going to do for management here? Well, we got two problems. Volume depletion. We already agreed a little earlier that there is no advantage in allowing a patient to remain volume depleted for a long period of time. We ought to correct that in a few hours. But she's also hyponatremic. Hyponatremic, but asymptomatic from the hyponatremia. She's awake, she's alert, she's not convulsing, she's not in coma. Her brain has had a chance over these several days when the problem has occurred to keep up with what's happening. Her brain is now functioning in the presence of a hyponatremia. If we were to correct that hyponatremia in a few hours, we would kill the lady or cause her grave harm because of the rapid correction of a hyponatremia. So what do we need to do in this lady? My choice for an answer would be a rapid, vigorous replacement of the fluid that she needs, but using isotonic fluids rather than hypertonic. I don't want to use 3% saline here or 5% saline, because I don't want that tonicity corrected very quickly. Obviously, I don't want to use a diluted fluid either, because I don't want to dilute her even more than she is. So neither D5W nor half normal saline would be an appropriate answer here. She already is hyponatremic. Let's not make it even more so. But if we give her isotonic fluids, we'll correct the tonicity slowly, even as we're correcting the volume rapidly. There are two fluids that would come to mind as appropriate under the circumstances. Either normal saline or Ringer's lactate. The choice would depend on what impact her problem has had on acid-base balance. If she is rather alkalotic, if she's been vomiting primarily acid gastric juice and she's on the alkalotic side, then normal saline would be a better choice. If she, on the other hand, has been vomiting mostly small bowel content, bile, pancreatic juice, alkaline fluids, and therefore she's rather on the acidotic side, then Ringer's lactate could be a better choice. But again, we want to replace volume with isotonic fluid so that the correction of the tonicity happens very gradually. Well, let's move on. We now have vignette number 47. A patient with severe diabetic ketoacidosis comes in with profound dehydration and the serum potassium concentration of 5.2. After several hours of vigorous therapy with insulin and IV fluids, the latter being saline without potassium, the serum potassium concentration is reported as 2.9. So the crux of this question here is how come that she had a serum potassium or he had a serum potassium of 5.2 and in a few hours it has gone down to 2.9? Actually, there's a pretty easy answer. This is an individual who's being acidotic for several days. In the presence of acidosis, potassium comes out of the cells in exchange for hydrogen. This excessive hydrogen in the blood, which is the definition of acidosis, part of that hydrogen is disposed of by putting it into the cells, and because we have to exchange particles that have the same electrical charge, the exchange is made with potassium. So potassium comes from the cells to the blood. But on the other side of this thing, the kidney sees in the blood a high level of potassium. And in a very simple explanation here that I'm going to use, the kidney doesn't know that this potassium belongs to the cells and eventually will have to be given back. The kidney simply detects a high level of potassium and dutifully puts it out in the urine. That's one of the jobs the kidney does. If this has been happening for several days, there has been a continued loss of potassium via the urine because the level in the blood has been high. And yet, at the time the patient comes in, the potassium is still high because he's still acidotic, and there is still that exchange, potassium from cells into blood in exchange for hydrogen from blood into cells. We then correct the problem. We correct the acidosis. All of a sudden, the hydrogen that was hiding in the cells goes back into the blood, and the cells say, give me my potassium back. But that potassium is in the toilet. That potassium has been lost in the urine over the past several days. And not surprisingly, a profound hypokalemia develops. And that is why, in the treatment of diabetic ketoacidosis, so much emphasis is always put on the fact that as soon as we begin to rehydrate the patient, as soon as urinary output is reestablished, we should begin to give potassium to the patient. And in fact, this is an example, as depicted in this vignette, where we can give potassium at what normally would be an excessive rate of administration. Let me touch upon that for a minute. It may come in handy with other questions. If we need to give a lot of potassium to a patient, the safe upper limit of the administration, the safe rate of potassium administration, is not to exceed 10 milliequivalents an hour. 10 milliequivalents an hour enables us to give a lot of potassium, because the normal potassium intake, what you and I eat in the diet, is about 75 milliequivalents a day. If you're giving a patient potassium intravenously at the rate of 10 milliequivalents an hour, it adds up to 240 milliequivalents a day, a lot more than normal intake, so it qualifies as a lot of potassium. But it's safe at 10 an hour, as long as the kidney is working, it's safe. If we exceed 10 an hour, we get now into the territory where bad things could happen. And we do sometimes do it if we know what we're doing. But when we give potassium at more than 10 milliequivalents an hour, all kinds of safeguards and precautions need to be taken. This example, though, the correction of a diabetic ketoacidosis, where that potassium dropped precipitously from 5 point something to 2 point something. It's a good example of where we deliberately would break that speed limit. And in fact, a rate that would be highly appropriate here would be 20 milliequivalents an hour for several hours. Well, let's look at another vignette where we have the opposite kind of situation. Vignette number 48. An 18-year-old woman slips and falls under a bus, and her right leg is crushed. On arrival at the ER, she is hypotensive, and she receives several units of blood. Over the next several hours, she's in and out of hypovolemic shock, and she develops acidosis. The serum potassium concentration, which was 4.8 at the time of admission, is reported to be 6.1 a few hours later. If we go back to this vignette, we should have no trouble identifying the many ways in which potassium has been added to the blood of this patient. We began with the fact that she had a crushing injury. The intracellular electrolyte is potassium. Those crushed, killed, smashed cells are going to free up potassium that goes into the circulation. She then came in, and because of her, multiple problems, got blood transfusions. Blood, when we take it out of the donor, has about 3.5 or 4 milliequivalents of potassium per liter. But as that blood sits in the blood bank, and hemolysis slowly takes place, the concentration of potassium in that blood goes up. And so this is blood that was already 1 or 2 weeks old. This is another source of potassium that has gone into her veins. She then became acidotic, being in and out of hypovolemic shock. Well, if she's been in and out of hypovolemic shock, her kidneys have not been working very well. The kidneys need perfusing pressure. In the absence of good perfusing pressure, the kidneys are not eliminating potassium as they normally would. Whatever high level of potassium exists in the blood has no way to get out. And when we're told that she developed acidosis, we recognize another way. Now there is a hydrogen going in from the cells, from the blood to the cells, and the exchange where potassium comes from the cells to the blood, another source of potassium in our blood. And so the serum potassium concentration has gone up very significantly. Okay, what do we need to do for this lady? If a level is reached of dangerous hyperkalemia, and this begins to qualify at that, this is above 6. The only absolute sure effective way to remove potassium if the kidneys are not doing the job is to do hemodialysis. Hemodialysis might in fact be appropriate here, but hemodialysis is not something you can snap your fingers and get it done. It takes a little time to find an opportunity for hemodialysis to be done. And there are therefore things we may need to do in the meantime. Now, what are those things? We could give this lady 50% glucose and insulin. That would create a momentary anabolic phase that puts potassium into the cells. This is routinely used. We could use the GI tract as a way to eliminate potassium. Nasogastric suction can do it. It's not terribly effective, but it could help a little bit. And we can use K-oxalate, the resins that exchange sodium for potassium in the lower GI tract. At one time, we used to prescribe also bicarbonate here, with the idea that if we create alkalosis, we'll reverse the traffic of potassium to and from the cells. The use of sodium bicarbonate in these circumstances has fallen out of favor, so that would not be one answer that I would recommend you look for. And then the other thing we can do, and probably the most important, we really don't care what the number is of potassium concentration. We care what that number does to the heart. The lethal event here is going to be cardiac arrest because of hyperkalemia. We can protect the myocardium with calcium. And so calcium given to this patient would be a highly effective thing to do while waiting for the hemodialysis. And in fact, if you were to be asked in the exam question, which of the following things would protect your patient most effectively and quickly? It would not be the insulin and the sugar, it would not be the K-axolate, it would not be the nasogastric suction, it would not be bicarbonate. It would be the intravenous calcium. All right, let's move on now to a couple of vignettes that deal with acid-base balance. Vignette number 49. An elderly alcoholic diabetic male with marginal renal function sustains multiple trauma while driving under the influence of alcohol. In the course of his resuscitation and multiple surgeries, he's in and out of shock for prolonged periods of time. Blood gases show a pH of 7.1, a PCO2 of 36, and his serum electrolytes include a sodium of 138, chloride of 98, and bicarbonate of 15. If we look at this vignette backwards, looking at the numbers first, we can very quickly establish a diagnosis. This patient has metabolic acidosis. We know he's acidotic because his pH is 7.1 instead of 7.4. We know we should not blame the lungs because his PCO2 is 36. If anything, the lungs are trying to help. He is hyperventilating. His PCO2, rather than being 40, is a little lower than 40 because he's trying to compensate by breathing faster. And so what he has is metabolic acidosis, which is further confirmed by the fact that his bicarbonate is 15. The normal should be about 25. So we have metabolic acidosis. Now, why do we have it? Metabolic acidosis, if we look at the various things that can be responsible for it, could be due to either excessive production of acids at the cellular level, insufficient buffering because we've lost bicarbonate from the body, or inability of the kidney to do the final necessary adjustments for acid base. We know the latter is not the problem because in renal failure it takes several days to develop acidosis. So even though it is not helping for this man while he's in and out of shock, isn't making very much urine, that's not the main problem. Neither do we have any evidence here of the loss of bicarbonate. Bicarbonate would be lost if you had a biliary fistula or a pancreatic fistula or massive output from ileostomy or perhaps massive diarrhea, but not in these circumstances. On the other hand, we have every indication that the endogenous production of hydrogen ion is way above normal because this patient is in a low flow state. We've been told he's in and out of shock, he's hypotensive, we know he's not perfusing well. If he's not perfusing well, his cells are no longer doing the normal aerobic metabolic pathways that lead to the normal production of acid. They have by necessity gone to anaerobic, far less efficient metabolic activity that ends up producing a large amount of acid. In fact, if measured, this man would certainly have high lactic acid levels in the blood. So what do we need to do for management here? Here's a very important principle in the management of acid-base balance. We always have to begin by correcting the underlying problem. And this is perhaps the best example of where that is important. And one reason that principle is important is because there is a shortcut that we could always use, a very tempting shortcut. If the patient is acidotic, if we realize it is metabolic acidosis, we can always give the patient bicarbonate or a precursor, acetate or lactate, that the body converts into bicarbonate, and we can tip the balance. By adding bicarbonate to a patient who has metabolic acidosis, we can help correct the acid base and drive the pH in the direction of normal. But if that's what we do here, that doesn't address the underlying problem. The underlying problem is a low flow state. If we were to simply manipulate the pH by playing chemist and adding bicarbonate to the blood, when the man eventually gets out of his problem, then he's going to have too much bicarbonate on board. He's going to rebound with alkalosis. It'd be far better here to address the underlying problem, which is the low flow state. This man needs vigorous rehydration. This man needs vigorous administration of circulating volume, so he's no longer in a situation of low perfusion, so he's no longer making lactic acid, and then he will correct the acidosis. So the proper therapy here, the one answer you want to look for, is rehydration, volume repletion. Now, it would probably be a good idea, as you do that, to pick a fluid that doesn't compound the existing acidosis. And in fact, I would not do the volume replacement with saline. I would use Ringer's lactate. But Ringer's lactate isn't purely a bicarbonate donor. Ringer's lactate is primarily a volume expander. Now let's move to the next one. This is vignette 50. A patient who has had a subtotal gastrectomy for cancer with a Billroth 2 reconstruction develops a blowout of the duodenal stump and the subsequent duodenal fistula. For the past 10 days, he's been draining 750 to 1,500 cc's per day of green fluid. The serum electrolytes show a sodium of 132, a chloride of 104, and a bicarbonate of 15. The pH in his blood is 7.2, with a PCO2 of 35. Well, if we look at the numbers again, like we did in the previous vignette, we can again identify metabolic acidosis. We know it's acidotic, its pH is 7.2 instead of 7.4. We know that the problem is not in the lungs. If anything, the lungs are helping. His PCO2 is 35. He is hyperventilating. He's trying to compensate. And we see, on the other hand, that his bicarbonate is 15 when it should have been around 25. This is, again, metabolic acidosis. But now we can also see an entirely different reason for it. The patient has been losing 750 to 1,500 cc's a day of a green fluid from a duodenal blowout. What made it green is bile. Bile is loaded with bicarbonate. Where you get bile, you get pancreatic juice, which is also loaded with bicarbonate. This patient has been having, in fact, a significant bicarbonate loss. He doesn't have enough buffer left to take care of his normal production of acid. This is a patient who needs bicarbonate. You see, in this case, giving him bicarbonate is not a shortcut that simply manipulates the acid-base balance. It would be, in fact, addressing the underlying problem being loss of bicarbonate. And so that would be the correct therapy here. Let me repeat, as I said before, bicarbonate can be given as bicarbonate. There are ampules. They typically have 44 milliequivalents per ampule, sodium bicarbonate. The sodium bicarbonate cannot be a component of IV fluids that are meant to be in a bag and stored in a shell for a long period of time, because it precipitates. It makes the fluids precipitate. And so the ampules would have to be added at the last minute to the incoming fluid. If we want a fluid that already has the bicarbonate in it, it has to be a precursor. And it would have to be either acetate or lactate. But either of those. Give the patient bicarbonate or acetate or lactate. That would be the correct therapy for this patient. The last vignette for acid base, and for that matter, the last vignette for the pre-op and post-op care, vignette number 51. A patient with severe peptic ulcer disease develops pyloric obstruction and has protracted vomiting of clear gastric contents. That is to say, without bile for several days. The serum electrolyte shows sodium of 134, chloride of 82, potassium of 2.9, and bicarbonate of 34. That electrolyte pattern is classical for hypochloremic, hypokalemic metabolic alkalosis, secondary to the loss of acid gastric juice. This man obviously needs to be rehydrated, and saline would be a better choice than Ringer's lactate. But he also needs something to correct his metabolic alkalosis. Let me talk about that a little bit. We can, if it is necessary, provide a patient with a hydrogen donor. Ammonium chloride is used for that purpose, or even hydrochloric acid. Now, please don't run now to the words and drip hydrochloric acid direct into somebody's veins, but we can give it diluted in an amino acid solution. The amino acid solution buffers the hydrochloric acid. This will be 1/10 normal solution. But let me emphasize what I said at the outset. We very rarely need to give either ammonium chloride or hydrochloric acid, because in most cases of metabolic alkalosis, all we need to do is help the kidney correct the problem. How does the kidney correct the problem? This is going to be a little bit of a long explanation and another one of those simplifications that are probably too simple for the experts, but good enough to review for the exam. Let's for a moment forget acid-base balance. One function the kidney is constantly doing is retrieving sodium from a glomerular filtrate. If that were not to happen, we would urinate about 150 liters a day and die. So we are constantly retrieving sodium from the glomerular filtrate. But that cannot just be like that. Sodium has a positive charge. In order to move that sodium in, it either has to come combined with a negatively charged particle as either sodium chloride or sodium bicarbonate, or it has to be exchanged for another positive charged particle, and the exchange could be for potassium or for hydrogen. So our kidneys are constantly retrieving sodium from glomerular filtrate, and as they do it, they have a choice of 4 ways to do it. We can retrieve sodium chloride, we can retrieve sodium bicarbonate, we can exchange sodium for potassium or sodium for hydrogen. If a patient is alkalotic, the definition of alkalosis is you don't have enough hydrogen ion in the blood. Well, then it would not be convenient for hydrogen to be put out into the urine in order to retrieve sodium. It would be better not to do that. By the same token, when you're alkalotic, you end up with a lot of bicarbonate that isn't being used to neutralize acid, and therefore sort of piles up in the blood. This patient we already read at a high level of bicarbonate in the blood. It would not be convenient under the circumstances for the kidney to be retrieving sodium bicarbonate from the glomerular filtrate. So we want the kidney in this situation, in fact the kidney is already trying to do that, but we want to accentuate the choice on the part of the kidney here not to put hydrogen in the urine and not to bring additional bicarbonate into the blood. Well, that leaves the kidney with the other 2 options. Bringing the sodium in as sodium chloride or exchanging sodium for potassium. If we give the kidney the appropriate raw materials to do that job, the alkalosis will be correct. So the 2 things the kidney needs are chloride and potassium. So we give this patient a generous intake of potassium chloride. That potassium chloride will enable the kidney to use the potassium for retrieval of sodium, to use the chloride for retrieval of sodium. and not to have to add more bicarbonate into the blood or put more hydrogen into the urine. Now, we went through this a minute ago. Let me say it one more time. What would be a generous administration of potassium chloride? The normal potassium intake is about 75 milliequivalents a day, so this would need to be more than that. The safe upper top rate of administration, not to be exceeded unless we have good reason to, is 10 milliequivalents an hour. 10 milliequivalents an hour adds up then to 240 milliequivalents a day. And a less vigorous administration, let's say 5 milliequivalents an hour, would still be more than normal intake, 120 total per day rather than 75. So bottom line, what's the therapy for metabolic alkalosis if we have good functioning kidneys? It's somewhere between 5 and 10 milliequivalents of KCl per hour. So a drip at 5 per hour would be sufficient to take care of a mild case of metabolic alkalosis, or we may choose to give 6 or 7 or 8, all the way up to 10 milliequivalents per hour if we have a severe case of metabolic alkalosis, and the kidney will do the job. Let me emphasize, the kidney will do the job. If you're giving a vignette of a patient in chronic renal failure on dialysis, chronic dialysis, who becomes alkalotic for some reason, then please don't pick the answer of a drip of KCl, because the kidneys there cannot do the job. It has to be functioning kidneys. Well, this concludes the review of the pre-op and post-op. The next chapters that we have will deal with general surgery, and then eventually another big group of vignettes that have to do with the other surgical specialties.